Hello everyone. Today we will discuss about sepsis in the newborn in the 5-mark short note series. Neonatal sepsis is a systematic infection in the first 28 days of life that includes septicemia, meningitis, pneumonia, arthritis, and UTI. Major causes of neonatal morbidity and mortality in developing countries. Systemic illness with bacteremia due to infection within 28 days of life is called as neonatal sepsis. So what are the two types of neonatal sepsis? One is an early onset neonatal sepsis, the other one is late onset sepsis. So in the early onset, it has to appear within 3 days of life, whereas in late onset, it has to appear between 3 to 28 days of life. The most common source include transplacental intrapartum transmission from mother. Usual pathogens are Group B Streptococcus, E. coli, Klebsiella, Listeria monocytogenes. In case of late onset sepsis, postnatal environment like a hospital or community is the most common source. With usual suspects will be like a Staph aureus, coagulase negative staphylococci, Pseudomonas candida, or E. coli. Coming to the risk factors. Maternal risk factors. Prolonged rupture of membrane of more than 18 hours, maternal fever, chorioamnitis, UTI, or vaginal infection. Then prolonged labor, multiple vaginal exams, poor ANC care are all the maternal causes that predispose to neonatal sepsis. Coming to the neonatal causes itself, it can be prematurity, low birth weight, birth asphyxia, using of invasive devices like IV line or catheters for other illnesses, unhygienic cord care, NICU stay, or nosocomial exposure. Coming to the pathogenesis, organisms reaches the bloodstream via three routes, either through transplacental route, ascending infection via amniotic fluid, or postnatal infection through contaminated instruments or hands. So the pathogens arrive through to the bloodstream through this. Once the pathogen arrives to the bloodstream, then the bacterial toxins trigger cytokine release, systemic inflammation, shock, and organ dysfunction. Coming to the clinical feature, generally there will be poor feeding, lethargy, temperature instability, that is there can be fever or hypothermia. In respiratory system there will be tachypnea, grunting, apnea, and cyanosis. In cardiovascular system there will be pallor, poor perfusion, hypotension, and shock. In gastrointestinal there will be vomiting, abdominal distension, and feeding intolerance will be there. In neurological there will be irritability, seizures, bulging fontanelles, which will be a sign, pathognomic sign of meningitis. In hematology, there will be petechiae and bleeding tendency for the newborn. Other miscellaneous symptoms or signs could be jaundice, sclerema, that is hardening of skin in severe sepsis. Coming to the investigation. So CBC will show leukopenia or leukocytosis, then CRP, micro ESR, and procalcitonin are the screening test. The confirmatory test include blood culture, which is the gold standard, CSF analysis. This has to be done only to rule out meningitis, urine culture for late onset sepsis, chest X-ray if pneumonia is suspected, and sepsis screening combination increases the sensitivity. Try to maintain temperature, fluids, and electrolytes. Oxygen and ventilation has to be supplemented as needed. Managing the shock requires 10 to 20 ml of 20 ml per kg of saline bolus, and we have to correct a hypoglycemia and acidosis if present. Then treating the seizure and monitoring urine output is essential. Coming to specific treatment. So the first line antibiotics for early onset sepsis include ampicillin and gentamicin, but we have to start immediately after the culture samples. Second line for late onset sepsis or resistant cases, or if there is no response between 48 to 72 hours, include cefotaxime, ceftazidime, or amikacin. Severe or hospital-acquired infections, multi-drug strains, piperacillin, tazobactam, or meropenem. In case of fungal sepsis, if risk factors are present or unresponsive to antibiotics, there could be fluconazole or amphotericin B. Coming to the adjuvant therapy, IV immunoglobulin can be given in case of severe immunodeficiency, or exchange transfusion can also be tried in case of severe sepsis or DIC. The complications include septic shock, DIC, meningitis, pneumonia, osteomyelitis, arthritis, and multi-organ failure. Coming to the prevention strategy, a good antenatal care and screening for maternal infection is non-negotiable. Clean delivery and cord care, hand hygiene and asepsis in NICU settings, avoiding unnecessary invasive procedures like IV line or catheter unless very strongly indicated, and promotion of early and exclusive breastfeeding. So the take-home message is mortality is higher in terms of preterm and low birth weight infants in case of sepsis. Early diagnosis and prompt antibiotic therapy improves the survival. Survivors of severe sepsis may have a long-term neurological sequelae. Always suspect sepsis in newborns with poor feeding or lethargy. This should be your first differential when the mother complains with poor feeding or lethargy. Early recognition, culture, and empirical antibiotics saves the lives. Prevention through hygiene and maternal infection control is one of the key elements to avoid. I hope you have learned through this presentation. Thank you.